Today I am presenting Mr. Perez. He is a 77-year-old right-handed Hispanic male with a pertinent history of hypertension, coronary artery disease, myocardial infarction with stent placement, hypercholesterolemia, and he's a current smoker. This patient was brought to the emergency department on the 9th of September 11 at 10 p.m. Because of elevated blood pressure on the range of the 200 to 210 over 100 to 115, I'm sorry. He also presented with left-sided weakness and diminished level of consciousness. According to his wife, although they brought him at 10 p.m. that night, all his symptoms started around 6 p.m. He started complaining of headaches and left side weakness. He decided to take a gram of Tylenol and go to bed. According to the wife, every time he was complaining of headache with any movement, talking, basically any activity. And the only thing they did for him was to give him Tylenol. They didn't check his blood pressure at that moment. That's why she said they didn't give him anything for elevated blood pressure. She said that he went to sleep, and then when she later on went to check on him, when he woke up, he had significant slurred speech, and so he ended up coming to the emergency department because of that. In the emergency department, they started him on hydralazine IV as well as a Cardian trip to decrease his blood pressure, and they started titrating it. They also did a CT of the head, and the CT of the head, the brain, I'm sorry, demonstrated a very large 5 by 7 by 4 centimeters right temporoparietal hemorrhagic infarction with right to left herniation. The CT also showed early mild hydrocephalus and left frontal lobe hemorrhagic contusion. The wife denies witnessing any seizures, head or neck trauma. They also did a check his LDL, and it was elevated at 115. His bleeding time was very elevated at 14.5 minutes, and his blood cultures, it came positive for gram-positive coccyte in clusters and pairs. His outpatient medications include lisinopril 10 milligrams a day, rosuvastatin 10 milligrams daily, Effient 10 milligrams daily, meloxicam 15 milligrams daily, and metoprolol 25 milligrams BID, and also aspirin 81 milligrams daily. It was decided to admit him to the ICU, and so we evaluated this patient in the ICU, and at that time no family member was present for a review of system, so I was unable to get my review of system due to his decreased level of consciousness. On his physical examination, his temperature was 99.2 degrees, his heart rate was 104, his respiratory rate was 39, his systolic blood pressure was 174 and diastolic of 87. His O2 saturation was 90%, and this was on 4 liters nasal cannula. General, he is a well-developed, well-nourished, moderate obese male. He was laying in bed with his head op-ed elevated at 30 degrees. He wasn't on any cardiorespiratory stress. However, during my examination, he did demonstrate Cheyne-Stokes respirations. For his mental status, he was stuporous. He did not open his eyes. He did not attempt to speak. He wasn't able to follow commands. He did not fixate or follow me when I opened his eyes. He demonstrated minimal, not for pulseful movement on the right extremity only. He will respond only to sternal rub. He did not moan and respond to the sternal rub. He only moved his right leg. However, he did grimace with masseter muscle pressure. For neck, the neck was supple. I did notice a carotid bruit on the right, but I did not notice one on the left. There was limited range of motion of his cervical spine. His carotid pulses were 2+. For his cranial nerve examination, it did reveal a left upper motor neural type facial weakness. There were limited horizontal extraocular movements with dull maneuver. The discs were sharp bilaterally. His right pupil was 3 millimeters in size, but it was sluggish. And the left pupil was 3 millimeters inside, but it was non-reactive. I was unable to assess for his hearing or his tongue protrusion because he was unable to follow commands. For his sensory examination, he did not respond to pinprick on the torso, the arms, the legs. However, he did respond to pinprick on the right side of his face, but not the left side. For the musculoskeletal motor, it revealed a flaccid left hemiplegia. The tone was increased on the right more than on the left. He was weaker on the right side as well. I was able to notice distal muscle wasting. There was no evidence of tremors or fasciculations. The left upper extremity was completely flaccid. For his deep tendon reflexes, I got a 3+ in the left upper extremity, 2 to 3+ in the right upper extremity, 3+ at the patella, left patella, and 3+ in the right patella. It was, however, absent on both ankles. There was no ankle clonus, and the patient had a triple flexion response with Vavinsky bilaterally, but more pronounced on the left than on the right. For his respiratory were uneven. He had episodes of increased respiratory frequency, and he was alternating these increased episodes of breathing with apnea. When he was tachypneic, he was breathing between 30 and 50 respirations per minute. His oxygen saturation level at that time started fluctuating. They were, for the most part, 70 to 90%, and this was on 4 liters nasal cannula. His lung sounds, they were decreased, but they were clear. For cardiac, the patient was in a normal sinus rhythm, tachycardic on the 1-teens. All his radial, carotid, and pedal pulses were palpable, 2+. His capillary refill time was less than 3 seconds. I was able to auscultate the S1, S2 heart tones. I didn't hear any murmurs, gallops, or clicks. I didn't notice any sinuses or clotting. His abdomen was soft, rounded, and tendon distended. He had possible bowel sounds in all 4 quadrants. His genitourinary status, he didn't have any genital discharge or redness. He did have a Foley catheter in place, and I noticed clear yellow urine. For his skin and his nail, he was warm, dry, pink, and his color was appropriate for his ethnicity. His skin was evenly pigmented. I didn't notice any redness, lesions, or cyanosis. So based on the results of the CT scan, the bleeding time, all the comorbidities that include hypertension, smoker, non-compliant with his hypertensive medications, the impression for this patient include a large acute right temporal lobe hemorrhagic infarction, flaccid left hemiplegia secondary to stroke, early hydrocephalus, bilateral subarachnoid hemorrhage, prolonged bleeding time, and bacteremia. The recommendations as far as they're going to include, we're going to continue current management in the ICU. We are going to agree with the plan of the intensivist to intubate because he was present during my examination and he suggested to protect the patient airway, so we agree to intubate the patient. We are going to transfuse these patients with platelet products. We are going to repeat a bleeding time after the transfusion. Hopefully we can get it under 9 minutes. So we are going, at the same time, we are going to arrange with a neurosurgeon in the case for a possible craniotomy, ventriculostomy, once the bleeding time is within normal limits. We are also going to continue to control his blood pressure with PRN hydralazine, and we're going to keep him on the Cardin drip as well. We are going to discontinue all anticoagulants. We are going to consult cardiologists as this patient has cardiac stents. We are going to start him on Decadron IV, 4 milligrams every 6 hours. We're also going to start the first dose of vancomycin, 1 gram, and then we are going to consult infectious disease. And then we're going to repeat a CT of the head once all of this is done for a follow-up on the bleeding. In summary, this patient came into the emergency department with a hypertensive crisis due to non-compliance with blood pressure medication, maybe related to smoking also, and drinking. So this patient, once he's stable after the craniotomy, he's probably gonna benefit from teaching on smoking cessation and medication compliance, and hopefully we can avoid further damage to him. Thank you.